Welcome to the podcast, Not Your Doc Anymore, where we address the issues essential for your health and provide information to help you become your best advocate. We encourage empowerment through education. I cannot emphasize enough the power of physicians who understand clinical practice and are actually counseling with patients on a regular basis and have had years of experience. Here to address the topic of prostate cancer is a spectacular urologist, Peter Fisher. Thank you for being on the podcast.
Thank you for having me. Spectacular. That's a great introduction.
Dr. Fisher is board certified in urology and practices at Granger Medical with a talent in laparoscopic and robotic surgery for diseases of the prostate. He received his bachelor's degree from Brigham Young University in political science and international relations. He then attended the University of Utah for medical school. Pete completed his residency training at the University of Michigan and is a proud alumni. Is that correct?
That's right on the money. And you should mention that when I was a medical student at the U of U, you were an OBGYN resident. We worked together
I remember
back
that.
in those years.
Those were good times.
Yeah, those were good times. And I'm super proud. I'm super proud of Michigan. And we lived there for a number of years, and we've been Michigan fans
How many
ever
years
since.
is your residency in urology? Is it 5?
5 years is what I did. A lot of people do an extra research year. There are all sorts of tracks into academics, private practice, or fellowship
Gotcha.
through residency.
Dr. Fisher works at many hospitals around the Salt Lake Valley, but we've had the closest association at St. Mark's Hospital. We've had so many valuable collaborations through the years, Pete, and I just want to say I value your expertise and promptness in addressing so many medical problems through the years.
Thanks, Daren. The feeling is mutual for sure.
I needed to tell you, Dr. Fisher, I was scrolling through many of my texts from you, and there have been many, but I came across this text 4 days after I had my career-ending spinal cord injury. And I just need to read this so that everybody gets a sense of the compassion that Dr. Fisher has. You said, praying for you this morning, these moments make me contemplate all the good you have been in my life. Med school, my wife's surgeries, collaboration, and hopeful plans. I really would like to have a close colleague in the barely escaped death club. It's lonely sometimes, so heal miraculously, my friend, and safe travels home.
That's awesome. That's every word of that's true.
Yeah.
I'm glad that you're well, and your miracle continues. It's really interesting.
And we won't do it today, but your miracle was quite amazing. In fact, I want to put on the show notes the podcast on which really where you go through your whole story. So I'm going to share that in the show notes and people can reference that if they'd like to have a great story. And we'd love to talk about that in the future as well. In fact, one of those parts in there where you said you spoke to the University of Michigan, I would really love to get a breakdown of those 10 points.
Yeah, I would love to do that too. Yeah, anytime.
Well, in preparation for this segment, I was reviewing prostate cancer, and to me, it seems like there's a lot of interesting conflicting data and stories. And so I'm so excited to hear your opinion as we address the topic. I feel like screening has played a crucial role in detecting prostate cancer early, as many cases might not become clinically evident without it. However, research that I see indicates that prostate cancer often progresses very slowly, with many men passing away from other causes before the cancer becomes significantly advanced. In fact, in one study, I saw that autopsy studies revealed that prostate cancer is detected in approximately 30% of men in their 50s and up to 70% of men in their 70s, which is really notably higher than the lifetime incidence of diagnosed prostate cancer in the general population. So anyway, I think it's such an interesting topic as we go, where you're looking at 5-year survival rates for early detection as high as 100%, whereas those that have metastasized, you're looking at a 31% survival. So anyway, we're going to get into a few of these
And it's
topics.
just such a confusing and interesting disease. And I have these conversations with patients every step along the way, every week of my working life. As a backdrop, I kind of figured out at Michigan in residency that these questions around prostate cancer are going to be part of my entire career. It is such a widely variable disease, and there's so few cancers out there that you just wait and watch because they're so slow moving and happen to so many men if they get old enough. And yet we still have way too many men die every year from metastatic disease. These questions are just a big part of my job and helping patients navigate these decisions.
It's good. Well, let's jump into the first question that I'd like to ask. Will you review some of the prostate screening cancer methods and how do advances in technology influence the accuracy and effectiveness of this screening?
Yeah, that's a pertinent question now because it's changed pretty substantially in the last 5 years. So traditionally, prostate cancer screening, if you really go back to tradition, is just a prostate exam, a digital rectal exam. And then this is, more than 40 years ago, looking for changes in the prostate, prostatic nodules that would then lead to a prostate biopsy and a diagnosis, a tissue diagnosis. And then PSA was developed as a screening test. PSA means prostate specific antigen. All men have some residual PSA in their bloodstream. It's a natural protein that's made by the prostate gland. It's just part of the male ejaculate fluid. And so that prostate protein in the bloodstream can be elevated in disease states. It can be elevated in non-disease states too.
Okay.
Well, we can get into that, but basically PSA and prostate exam as your baseline screening tools for prostate cancer. There are a lot of different submutations of PSA out there, and this is an ongoing kind of, and this with research, a diagnostic test becomes attractive as being more effective than PSA, and then it falls by the wayside. Then it becomes something else becomes attractive, and it falls by the wayside. I bet you I've seen six
Yeah.
different mutations of PSA come through the screening portal, but still total PSA is just as good a screening tool, in my opinion, as any of those mutations. And then what's interesting in the last 5 years is how much better screening has, not necessarily screening, but detection of prostate cancer through imaging. And that's MRI imaging. We do prostate biopsies in the office with ultrasound guidance, but most of us in practice are utilizing MRI imaging. We do prostate biopsies in the office with ultrasound guidance, but most of us in practice are utilizing MRI as a way to look at prostate pathology or the potential for prostate pathology when we have a patient who qualifies for a biopsy. So what that looks like is a patient who has either a prostate nodule or an elevated PSA. Instead of just,
what's the number?
It varies with age. Typically, we go by decades. So a PSA for a guy who's under 50 ought to be less than 2 or less than 3, and that 2, less than 2 or 3, depending on if they have prostate infections or urinary infections or other stuff. For guys age 50 to 60, you're looking at less than 3. For guys 60 and over, you're looking at less than 4. And interestingly, a PSA test can be somewhat irrelevant in guys over age 80 because PSAs become higher as men age. And then you're also dealing with men that are very unlikely to die from prostate cancer. And so most of us feel that screening prostate cancer for guys after 80 is back to just doing a prostate exam. That's the case where, and this could be harmful to an individual's quality of life. You find prostate cancer in an 80-year-old that's never going to impact his life, and then face him with the stress of decisions and the potential harm of treatment like surgery or radiation or so forth. We can get into that. But MRI, to answer your question, as a screening tool, prostate MRI is pretty new. And I would say, if I were to estimate in Salt Lake City right now, I'd say about a third to a half of men are getting a prostate MRI before going through a prostate biopsy. So, so
Interesting.
that's on the verge of things new to happen.
You think that's helping in the over-diagnosis or under-diagnosis? So what is happening with the MRI? Is that helping us differentiate those that are going to need biopsy?
It's helping us do fewer biopsies, and
Okay.
it's helping us do biopsies where prostate cancer is most likely to be. The prostate gland is a
Okay.
reproductive organ. It sits between the bladder and the urethra, deep inside the pelvis. And putting a needle from outside the body into the right area of a prostate when you're dealing with a cancer that may be a few millimeters in diameter, that can be a difficult target to reach with a needle.
For
And
sure.
so having an MRI show us a lesion really makes a difference to target that area of the prostate. And I think leads to fewer biopsies on one hand. So targeting is part of it. But the other part of it is that we have guys with large prostates, PSAs higher in men with big prostates. And then getting an MRI often shows no prostatic lesions concerning for cancer. And those are guys that I would not do a biopsy of.
Gotcha.
I would tell them their PSA is elevated because they have a 2 or 3 times normal prostate size. And let's address their urinary symptoms if they have them, or just continue with PSA screening and an annual prostate exam,
So that's it.
and maybe repeat an MRI.
Is that how you do? Is that the frequency? Because it is slow growing. What do you typically do?
It depends. We'll have to assess risk, as you know. So men with a family history have essentially a 2 times risk of prostate cancer than the lay population. And family history, at least in prostate cancer, is primary male relatives. So brothers, fathers, sons, as first degree male relatives put you at risk. Generally speaking, if your PSA is very low, then screen every 1 to 2 years is plenty safe.
Yeah.
If you have an elevated PSA, or you have a prostate nodule, or you have an MRI that was abnormal but a clear biopsy, all of these things that may put you in a gray area. Sometimes I'll do PSA screening every 6 months in higher risk individuals. Your listeners should know it's hard for me to pinpoint if there is cancer that's slower growing than prostate cancer, by and large. And this is always difficult to educate patients about, because you hear this C word, you hear cancer,
Yeah.
and immediately you just think, oh man, this is a death sentence. And it still blows patients away when we say, hey, this can be a disease that can be followed, that may not impact your life or longevity ever. And those are conversations I have with men, seems like at least every week, if not every day of my working career, because prostate cancer moves slowly in its early stages. But then, like any cancer, as it advances, as it becomes more aggressive, then it can move quickly and it becomes life-threatening. Man, we've been through such a gauntlet of experience with especially primary care physicians, from screening all of their patients for prostate cancer to then screening none of their patients for prostate cancer, saying that, hey, this isn't even a disease. And then as urologists, we watch men go, the occasional man shows up in the emergency room with metastatic prostate cancer that never had a doctor visit, to that number starting to triple or quadruple years after you find that screening recommendations have changed. And that's it. Just even in my career, just being out in the community almost 20 years now, I just watched this pendulum just gradually swing side to side from an underdiagnosis stage to maybe an overdiagnosis stage. And we're trying to find it in a way that maximizes patients' quality of life, that keep them informed and educated. But we also, man, we never want to hurt people by their treatment, right?
Yeah.
And I'm sure we'll get into that. I tell patients it's better to have prostate cancer treatment now than any other time in human history because people are still nervous about the next treatment. I don't blame them.
Yeah. Okay, so before we get off the topic of PSA, where do you stand on PSA screening?
So there's two ways to think about PSA. There's PSA as a screening tool, and there's PSA as a follow-up tool to prostate. So someone who already has prostate cancer. As a screening tool, I am going to be biased on the side of PSA is valuable, right? I'm the guy that
Sure.
sees men die from prostate cancer. I see patients deal with the real dangerous sides of this disease and help men through even the more challenging sides of therapy. So I think PSA is valuable as a screening tool. I do think it has to be viewed through a lens that it's not a perfect screening tool, that it just gives us direction. That's where MRI for me is really helpful. Using imaging combined with PSA to really start to assess, is this disease that we need to follow or need to biopsy or need to treat, kind of work down that decision tree. As a follow-up tool for PSA, I hope you like this statement. I tell my patients every cancer wishes they had a PSA test. Yeah. In other words,
for sure,
when a patient's been treated for prostate cancer, the only follow-up they need is a PSA test, is a simple blood test, and it's available in every lab you go to.
Yeah.
And that is such a valuable, that's such an easy thing for patients who've had cancer to get screening with. You know, in your patients in the gynecologic world, breast cancer, they're getting follow-up MRIs and ultrasounds and blood work. PSA for prostate cancer stayed first out of the gate. Yeah. And we really only investigate other modalities if PSA is out of whack. So I still stand by that notion. I was told to me by Jim Monty, he trained me at the University of Michigan, every cancer wishes they had a PSA test.
That's great. Okay, awesome answers. Can you explain how someone can determine their personal risk for prostate cancer and what steps can they take if they are at high risk? So let's say they're listening today and they want to know if they're at high risk.
So I already said the first-degree male relatives, knowing our family history, I think with all cancers is becoming more and more important. Understanding the genetic kind of basis and risk involved with cancers in general. But first-degree male relatives really make a difference.
So just to explain real Pete, so that's a brother or a father.
Yeah, a brother, father, or sometimes sons.
Or sons.
I'll have men,
sure.
In their 60s or 70s saying my son was diagnosed with prostate cancer. So brother, father, or sons. Sometimes though, I'll have a patient come in and say, hey, I had two uncles with prostate cancer on one side, one uncle with prostate cancer on the other side. I start to feel those individuals at a little higher risk myself. Sure. There are some cultures a little higher prostate cancer. African-American culture is higher risk for prostate cancer than other kind of American cultures in that regard. There's one pretty common, obesity and prostate cancer have relation there. And so obesity and risk to higher risk prostate cancer when it's diagnosed. And strangely enough, Agent Orange exposure.
All right.
Agent Orange is pretty rare anymore, but some of these heavy chemical exposures can be cancer risks. That's the only one we know of correlated with prostate cancer.
Do we know the reason behind obesity and prostate cancer increased risk?
So the real issue there is that it has been shown that men with obese men are more likely to have higher risk cancers. Okay? And don't really know the exact correlation. It probably has something to do with oxygen tension, or just general tissue stress. But if you look at men who are diagnosed with prostate cancer across the board, obese men are more likely to have higher risk disease at the time of diagnosis.
Interesting. Because for women, it's because of the peripheral conversion to estrogen.
That makes sense. There seems to always be more research dollars going into female cancers like breast cancer than men's cancers like prostate cancer. And so we always feel like we're a step behind the research game in prostate cancer compared to breast cancer in particular.
Okay. Is there any role for genetic testing to assessing one's risk?
Yeah, you talked about that question earlier, and it's interesting for prostate cancer. We don't have super strong correlations with genetic risk like the BRCA genes with breast cancer. But there is a BRCA risk with prostate cancer as well. So it's an interesting thing. Should we have men screened for BRCA gene? Probably not all men, but a strong family history guy or a man who's got a lot of breast cancer in his family. If there's especially a BRCA gene propensity, then I think that I would want to get closer screening if that was me.
Okay.
Where genetics has been really helpful in prostate cancer is actually assessing risk once a diagnosis is made. So we have multiple genetic tests to be done on the cancer cells themselves. So after a patient receives a diagnosis, then genetic testing on their cancer
Interesting.
helps us determine how high or low risk this is. And those tests are super valuable to us. They help us determine like 5 and 10-year mortality rates.
Wow.
They help us decide if a guy has a real dangerous disease or if he's got a sheep in wolf's clothing sort of disease. In other words, he could have, the pathologist may say, hey, this looks scary or high risk, but his genetic risk is low, or vice versa.
So what genetic testing is being done on the tissue?
So generally they fall into, and now you're getting out of my league as a community urologist,
Sure.
Someone with a boots on the ground guy, but the biochemistry involved has to do with a multitude of factors, like what kind of cell signals we're looking at that make a cell replicate faster.
Sure.
What sort of cells are we looking at that are more likely to spread into nerves or blood vessels?
Yeah.
All these other genetic markers. I mean,
But it's
I forget the total number.
receptor testing, like it's testing for receptors like the HER2 receptors
It's all,
and estrogen receptors.
and a lot of PCR, right?
Gotcha.
They're looking at specific genes, specific genetics that have shown increased risk of prostate, higher risk prostate cancers in certain genes. And when you look at a panel of 50 of those genes with a prostate cancer cell, and you've got, half of them as showing high risk, then that makes for a higher risk disease, even if under the microscope it looks like low risk disease.
This message sometimes can go to people who are going to seek care or for actually healthcare providers. So I'm just going to ask this question for them. How can healthcare providers better support patients in understanding their screening and treatment options? Maybe let's just put it one step before you.
When I talk with docs about prostate cancer and prostate cancer screening, I tell them, look, I still see too many men in my practice with metastatic prostate cancer that present with high risk metastatic disease. When we wait till this disease is symptomatic, we've waited too long. We can gain some years on these men with treatments, but we can't cure them. And so there still has to be a balance between over screening and under screening. And I think still a lot of our primary care docs skip a prostate exam, skip a PSA test, because they've heard in the past that the treatment is worse than the disease. And I just try and tell them that that's not true. The disease is very real. It's very damaging. And I remind them that, what treatment was like 20 years ago is a lot different than what treatment is now. The percentages of men with incontinence or impotence, those are the big fears with prostate cancer treatment, are lower in 2005 than any other time in human history.
Wow.
So treatment is dramatically better. And that's what I try and remind them. This is, we should be facing this disease rather than sweeping it under the rug.
I love it. Any lifestyle changes that anybody can make to help reduce their risk of prostate cancer?
We talked a little bit about obesity. I think that's really more of a morbid obesity issue. The other thing with men, I think, has to do with understanding your risk. We touched on that as well. As far as lifestyle, you would know as well as I that when men are fit, especially, there's some diseases that you can't protect yourself from, and a lot of genetic diseases are that way. if you have the genetic propensity for prostate cancer and you live long enough, then it's probably going to get you. And it's a question of how risky it is. If the risk is enough that you're going to need treatment, your treatment will be more successful. In other words, maintaining your full quality of life after treatment. If you're a physically fit person, surgery is easier on fit individuals. Generally, fit individuals have a higher likelihood of bouncing back after radiation treatment if that's what they feel. If for guys who are not obese, they're less likely to have higher risk disease. So those things make a difference. I get asked all the time about dietary things, and if it's all right, let's just touch on that while we're here.
Yeah.
Because there's been so much studied in prostate cancer, from zinc to selenium to vitamin D to antioxidants to pomegranate juice. So these are things just like PSA mutations. They seem to come into the light for a little while and then they fade out. There are studies that say, oh, this diet may make a difference, and then actually this diet doesn't make a difference. It's interesting when you really look into the nutritional aspects of prostate cancer that the biggest difference for prostate cancer prevention and treatment, as far as treatment success, has to do with regular exercise, regular physical fitness. Patients do better, and regular aerobic exercise makes a difference. There are some real picky things, like pomegranate juice probably helps guys with higher risk disease. We don't know why. That's something that's still out there. There are these questions about other certain antifungal agents that seem to reduce PSA numbers in guys with prostate cancer. That's a real confusing part, and you probably ought to edit it out because it just makes people nuts. But it's interesting that the dietary things out there, I listened to a really brilliant guy talk about this. He went through 20 different dietary recommendations, and ultimately he came down to regular cardiovascular exercise is a better protective agent than anything dietary. I would still recommend that patients just have a balanced diet, but I focus way more about diet on the effect of kidney stones than I do about prostate cancer.
Gotcha. So this may be a little bit redundant. What are some common misconceptions about prostate cancer prevention, and what does the evidence actually say?
I think the misconception is that prostate cancer is not a dangerous disease and we don't need to screen for it. And we've talked about that. The evidence still says that prostate cancer is the most common organ-based cancer killer in men in the United States anyway. So this is still a very prevalent disease. The evidence suggests that screening still is of value. And that's been an argument for a long time, that screening men, especially men with higher risk, a family history risk, that it's a valuable thing to do. I do feel like the evidence that we get, and this, is 10 to 20 years old, right? We get evidence about diseases after it's been heavily scrutinized by the academic market. And we're always dealing with this variable timeline to say that, man, we're smarter about screening with prostate cancer now than we were 10 years ago. But we're basing our decisions on screening now as studies that were done 10 years ago. So it's a moving target. That's always a challenge.
Before we get too far in this, I had thought about it. I don't know what it's like for you, but when I'm with a group in a social setting and I want to be funny, I always preface this, comment with I'm a gynecologist. And so I don't know what's funnier to say that or to say, I'm a urologist. What are your thoughts on that?
Oh man, I find great value in the humor that surrounds our jobs. What I tell people is you cannot take yourself too seriously and be a urologist. And there's a lot of benefit to that. I really gravitated towards this field because I felt a kinship with the docs who are urologists.
Right.
They seem to have an attitude similar to mine. We trained in the same place, and surgery disciplines, I think they go somewhat by institutions, but your toxic surgeons were, at least where we trained, they seemed to be in the same camps.
Yeah.
You had these areas of toxicity, and from my perspective, I just didn't relate to those docs who were difficult, those surgeons who were difficult. And I thought, man, I don't want to work with people like that. And so in the urology world, I found people that were a lot like me. They joke pretty readily behind closed doors. I never want patients to think that we're joking about them in a
No.
pointed
No.
individual sort of way. But man, to talk about the things we deal with on call and the things that people do in moments of sexual desperation, there's some humor there. It's unavoidable. I don't preface things by saying I'm a urologist, but I say, look, in my line of work, there's nothing you can say that surprises me. People ask me all the time why I decided to do urology. And I should tell you this. I thought I'd be a pediatrician when I started medical school, just committed to pediatrics. Third year, when you do rotations, I put pediatrics at the end of the year. So I'd be a well-seasoned third year med student.
Wow.
And I put surgery and gynecology, OBGYN at the first two rotations, just to get them out of the way so I could kind of cut my teeth and make my mistakes in those disciplines. And I loved the operating room. I remember one of the fellows in vascular surgery. He said, Fish, what are you going to do? I said, I'm going to do pediatrics. And he said, you're a surgeon and you just don't know it yet. And you said something to me similarly that next 6-week block in OBGYN. And then I started thinking, man, maybe I am a surgeon. Maybe I want to do surgery. And so I started looking at various disciplines in surgery. And it was Jim Reynolds, who's a urologist. He was a urology resident when you were an OBGYN resident. And Jim said, Fish, what are you going to do? And I told him my journey, and I told him I was interested in ENT or plastics. And he said, what about urology? I was very honest. Jim and I are still close friends. And I said, Jim, I think all you take care of are old guys with prostate disease. And quite frankly, you're dick man. and, and Jim was awesome. And he said, the first thing, you're wrong. And just go to the medical library, look up this surgical text on urology, because yes, there's prostate disease, but there is so much variety, more than you think. And now, a third of my patients are women, probably more than a third of my patients are women.
Yeah.
I deal with just as many men under 50 as I do with men over 50. The variety of surgical stuff that I get to do and the disease I get to be involved with is way more than I gave it credit for as a young medical student. And then Jim said, as for being dick man, it's absolutely true. And it's the best kept secret in surgical medicine. And the reasons for that were just like what I said. You're going to struggle if you have a God complex and be a urologist.
Yeah.
Because even the other surgeons make fun of you. And at the same time, what can I say? I think it's the greatest job. I do think the stories that I get to deal with can be very comical. And of course, I leave individuals and names out of those things. But let's face it, when someone puts a foreign body in their urethra and I have to be the one to fish it out, that I think any audience, well, not any, most audiences will find some degree of humor with it.
That's great. Okay, well, we digress. That was a good digression, though.
It was a good digression.
Okay, so we're going to get back to prostate cancer just a little bit, and maybe this is advanced from screening, but what should a listener do if they have symptoms, and what are those symptoms, and when should that be evaluated?
This answer has changed for me because I used to just be so gung-ho about get to a urologist, see a specialist. I really love our primary care network. And I have learned by experience that primary care physicians are really terrific docs. And they know so much urology, just like they know so much gynecology.
Yeah.
And so I've changed my tune and tell patients, look, if you think you have symptoms of prostate cancer, start with your primary care physician. And if you don't have a primary care physician, get one. There's just so much value in having someone who knows what viruses are going around the community and
Yeah.
has the experience to say, oh, you have a weak urinary stream. Let's just check. Let's do all the easy stuff first,
Yeah.
because that's eliminated there. So first thing is, if you think you have symptoms, look to primary care. Super valuable, and oftentimes fixes an easy problem without the stress and worry of going to a specialist. If you get sent to a specialist, then we're going to look at the issues of urinary symptoms, of a prostatic nodule, of a PSA test, of age, of family risk, of prostate size. If this is not a cancer problem, maybe it's just a prostate size problem, because men are getting older and older as every year goes past. We're living longer, and urinary symptoms are so common. And the vast majority of them have to do with age and prostate size and an aging bladder. And very rarely do we see symptoms of prostate cancer, only in its advanced stages.
Gotcha. Great answer. All right, we're going to get into some of the common treatment options for prostate cancer and how do they vary by stage or type. Let's maybe just walk through some of this. This is going to be, I think, the meat of what we're going to talk about.
Yeah, let's do it. Let's jump. Most all of us will get a patient through a biopsy, an MRI and a biopsy, and then jump them to an office visit that we can sit down and talk over options. The first thing I say to patients is, we need to decide if this disease requires treatment or if it can be watched, and tell them how slow moving prostate cancer is.
Okay.
Try and kind of diffuse the bomb that's going off in a patient's mind when they've been diagnosed with cancer about, oh my gosh, I got to show my wife and kids where all the financial documents are, because the C word has been mentioned. But this is a slow moving disease. So the first question is, can we watch this disease or does it need treatment? And, that's going to really depend on some of the stuff coming into it. PSA, what kind of nodule there is on an MRI, but then the pathologic grading scale, it's called the Gleason score.
Okay.
And then the genetic score. And I use prostate genetics, the genetics of prostate cancer, for every patient with a new diagnosis assessing risk. It's just part of how I talk to them about where we're going to go. And then their age and their fitness level will also help determine what treatment they're going to have. So let's say we have a patient the easy one is this: someone with very low risk disease of an advancing age who's likely to have disease that's not going to influence their life. They get placed on a course of active surveillance. That generally means a PSA test every 6 months, a prostate exam once a year, an MRI, or either repeat an MRI or repeat a biopsy at every couple of years. Everybody's a little variable on how they do active surveillance, but that's pretty straightforward.
What sets somebody in the low risk category? Is that the Gleason score?
It's a combination of PSA, pathologic score, clinical stage, in other words, how bad their prostate feels or how bad it looks on MRI, and their genetic testing. And so any of those measures can edge you up towards higher risk. If someone's got a very high PSA, but a low Gleason score and a low genetic risk, we're kind of scratching our heads like, did we miss something? Is there something worse in the prostate that we just didn't tag or target?
Yeah.
And the same thing goes for the other side. Rarely do we see high risk disease on biopsy have low genetic risk, right? But it's frequent that we see medium risk disease have a low genetic risk. And that's valuable. And it's also the volume of disease. How much is there? So there are all these factors in play that start to tell you, in my mind, this patient's going to need prostate cancer treatment. And when we get there to a patient, then real treatment options are still surgery or radiation. Those are the leaders. There have come and gone a number of other therapies, and some of them still hold a little bit of a place. But for the sake of your listeners and for the honest truth about about what is most likely to cure prostate cancer, it is still surgery or radiation.
Okay.
There are things like high focused ultrasounds that still show a little inferiority compared to surgery or radiation. And these are things that we just hope we continue to fine tune. Surgery and radiation are still the mainstay treatments. Generally, you can always salvage recurrent disease after surgery with radiation. If you have recurrent disease after radiation, you can't, those patients we're going to struggle to operate on.
Right.
So we're going to have to either radiate them more or look at hormone therapies.
I think you mentioned it a little bit, but maybe let's just elaborate it on a little bit more. What are some of the risks that somebody worries about when they go through prostate surgery for cancer?
I tell patients once we get through that, if we're going to have treatment, I tell them what the details are of surgery or radiation, what to expect, and to say that we're always thinking about the trifecta of disease. I got this from my partner, Lane Childs. So we want to cure prostate cancer. We want to maintain urinary control, or nowadays even improve urinary control, and maintain sexual function or erectile function. Or as Lane always said, life, liberty, and the pursuit of happiness. I always liked that. Yeah. Those risks matter a lot to men. Modern surgery, which nowadays is almost all robotic surgery for prostate cancer. For medium risk prostate cancer, we have roughly around a 90% chance of curing disease with surgery. And it's also a 90% chance with radiation. They're pretty much the same.
Okay.
I tell men with robotic surgery, we've dramatically improved our chances of maintaining urinary control. Those are men who don't need a pad for any degree of leakage. And we usually measure that at 3 or 6 months after surgery. And thankfully, those numbers are very low less than 5% risk.
Okay.
Probably.
Wow, that's amazing.
For a lot of high volume surgeons, we're talking about a 1 or 2% chance risk. That's really great.
That's awesome.
And erectile function is more of a challenge, but you're also talking about a disease that used to have more than a 50% chance of permanent erectile damage. Nowadays, that number is closer to 10%.
Wow.
Then you're really looking at fine tuning the numbers because younger men are more likely to maintain better erectile quality after surgery or radiation for that matter. So we kind of divide it by decades. I tell patients, and this is variable, I tell patients under 60 that if they're sexually active before surgery, there's a 95% chance that they'll be sexually active after surgery.
That's great.
I tell men after age between 60 and 70 that number drops by, that number doubles. So 90% likelihood that they maintain erectile function. And after 70, it really depends on the quality of their erections going into surgery. And it's also a much lower number.
Sure.
Nerves and vessels that help with blood flow to erectile function are very fragile, and they get more fragile with age.
Gotcha.
That's been a pretty well repeatable test. So guys who come in their 70s and say, I have prostate cancer and it can shorten my life, generally speaking, I aim them towards radiation. If they say, look, I just in my guts feel I want to have surgery, I tell them I'll go down that road with them, but they may lose erectile function naturally. We got to use medication after surgery. Okay. I just have that frank talk with them.
That's great. So it seems like we're seeing cancers in younger ages. Are you seeing younger patients present with prostate cancer, or is that not been something you see?
No, we are seeing that, and we're seeing it because of this family history propensity. And so most of the time, younger men that we see with disease, the youngest guy I've operated on was 37 years old.
Wow.
With prostate cancer. And I seem to see them younger with regularity. And usually it comes through a family history disease, getting on top of screening earlier in their 40s or early 50s and getting disease diagnosed, disease that could be dangerous in the term of 10 years. Hey, when you're in your late 40s or early 50s, that's a short timeline.
Yeah.
Right? That's worth treating. So, one of our colleagues, a physician I just operated on It hasn't been a year yet, but he was in his 50s, family history of prostate cancer and abnormal PSA, abnormal MRI, diagnosed prostate cancer. Interestingly, pathologically low risk disease, but in high volume, genetic test, medium risk disease. And I remember this individual, when we were in medical school, his dad was treated for prostate cancer with a conventional open prostatectomy and dealt with incontinence and impotence the rest of his career. And this friend of mine said in medical school, and I was in urology, he said, look, if I get prostate cancer, you can carve that prostate out of my cold, dead corpse, because there's no way I'm going to go through what my dad went through. Then fast forward 25 years, and he's diagnosed with prostate cancer. And I reminded him of that conversation. We operated on him a year ago. He's fit, young. He was continent within a week or two, pad free very quickly and running. He was so thrilled.
Wow.
That was a couple of months after his surgery. And those are success stories that honestly we didn't have.
Yeah.
Or we rarely had in my training. That's just where surgeries have improved, robotic surgery in particular. It went from being unheard of when I was in medical school to now I would venture 98% of prostatectomies in the United States are done robotically.
Wow, that's great. I do think that's a great use for the robot.
Yeah.
How can patients make the most informed decisions about their treatment plans? And this may cover a lot of the stuff that we have addressed, but when somebody comes in and you're wanting them to be informed, what do you think is their best way to get there?
So, I think this is a tough question because the pharmaceutical industry puts a lot of effort and money into educating patients, but there's always a little bit of bias there, right? And it can be kind of sneaky. And I get that that's kind of what they do. There's still way more interest than most people have to look at the NCCN guidelines. That's the National Comprehensive Cancer Network, right?
Yeah.
NCCN. I point patients in that regard because it's dizzying, but at least I know that they're getting a lot of up-to-date, unbiased information there. But for a practical sense, because most patients really just need practical guidance.
Yeah.
I encourage them to get multiple opinions and to talk to people. It's embarrassing. Men are still more difficult patients than women, in my opinion.
For sure.
They don't talk about their illnesses. And I have to encourage patients to open their mouths, to ask their neighbors. I'm always shocked at a guy says, man, I asked my neighbor and he had prostate cancer. And he knows 3 other guys in our neighborhood who had prostate cancer. I never had any idea.
Yeah.
So it's way more common than you think. So I encourage patients to ask their friends, family members, their primary care physician, and get other opinions. I try and tell my patients, look, nobody's bucking for your business here. It doesn't hurt my feelings if I diagnose your disease and somebody else operates on you. And it shouldn't hurt anybody else's feelings if they diagnose you and I operate on you. You need to get all your questions answered and be able to have a partnership with whoever's going to treat you, whether that's a surgeon or a radiation oncologist. I really believe in that personal relationship because any medical procedure is going to have the potential for pitfalls, and you have to be able to address things honestly. You have to have access to your docs. The last thing you want is to have a question and feel like you were left on an island.
Yeah.
So that's a lot of the choice and proximity, right? Where people live can make a difference, where people are willing to travel. There are very few things in prostate cancer. I honestly don't think of any that I tell patients to leave the state for, right? Or to go to any rare academic institution. In fact, I encourage them not to. I say, you know what? You want the docs who treat you to understand how they've helped patients through any degree of bumps in the road or complications or otherwise. And if they haven't treated you, it's going to be hard for them to help you when you're the patient in their backyard.
That's good advice. Thanks.
Yeah, no problem.
Just to follow up on some of that, how can friends and family best support someone going through prostate cancer treatment? And I think it's also speaks of, are you willing to talk about it?
It sure does. Boy, 10 years ago, maybe a little longer, 10 years ago, I started doing a prostate cancer run for prostate cancer patients and survivors for this exact purpose. Honestly, it could be a much better attended run. I think I have partners who are doing that run now who do a better job of it than I did. But it comes down to just opening your mouth and involving your network. That's the circle of the people around you. It's a common disease. To talk about it, not just for the patient with the disease, but for caregivers. There's going to be a wealth of information once you start talking about it, that you'll find things that resonate with you. You know, spouses helping out spouses, family members helping out family members. I got to tell you, I think daughters are the best for my prostate cancer patients. It is with these guys and their families that come to the prostate cancer run. Often it's their daughters who have put together a whole family event.
Wow.
Like, hey, let's raise money for prostate cancer. Let's go and do a 5K. Let's take a Saturday morning to support dad, that we're all out there for him. Let's invite all our friends. I love that stuff, man. It's a difference maker for patients. It gives them the strength to be able to say, hey, I'm a little nervous with how my body's reacting in this regard. And then they can seek answers rather than just waiting nervously, like, what's going to happen? Or I'm not happy with my erectile function or my sexual function. And they just are embarrassed to ask. Those are all the things that kind of help to break down the armor.
That's awesome answer, Fish. All right, this is the summary. What are the 5 things that you would like listeners to know to help them better understand prostate cancer? That's just a summary for you.
Yeah. So I've given this question a lot of thought, Daren. And honestly, I think there's a practical and a philosophical way to answer this question, because prostate cancer is a disease that is found before there are symptoms. And so often you have men that say, wait a second, wait, time out. This is disease that's not going to be dangerous to me for a decade, but you're putting my quality of life at risk in the here and now.
Yeah.
Right? Are we even sure that we should be doing any of this?
Right.
That's challenging. And I like to think about that as far as for my patients, it is trying to find the balance and honestly, the kind of inner peace that you can find with your life about the risk of accidents happening to any of us. You and I understand that.
Yeah.
You had a spinal cord injury. I had a sudden cardiac arrest. Some people are going to be diagnosed with cancer when they have a lump on their neck, and other people can be diagnosed with cancer when they have no symptoms right now at all.
Right.
Right? I think the main thing, this list generally comes as like a 5 things, not like the old top 10 lists from number 10 to number 1, but from number 1 to number 10. And so in mine, I'm giving you the division first of a philosophical sense, that there has to first be an inner peace about who you are and that you're vulnerable. I think vulnerability matters a lot, and it's strengthening. It will strengthen you as all of us age. It'll strengthen you through disease, not just of your own, but other people. So that inner peace, that vulnerability are important. And then I think surrounding yourself with a team, talking about it, again, from a philosophical sense, this becomes very practical very quickly, because you get things to read that resonate with you. You get to talk to somebody who had a great doctor or a great experience in a certain clinic or a certain hospital. And those things really help to guide patients. So I think that would be my number 2 is talking about it. And I just beg my male patients to not be silent about this disease or,
Right.
any of their diseases.
Sure.
Men are just that way. The third thing that I would tell men, again, from a psychological kind of standpoint, is to trust their doctors. The information age in some ways makes our job so much harder. And there are so many nuances to individualized care.
Yeah.
in my feeling, I love being part of the medical practice and the medical physicians and docs and caregivers, because at our core, we really got into this to help people. And that's at the core of what we want to do. We're not trying to sell people things. We're certainly not trying to give people treatments that are going to hurt them. At our core, we're trying to give them the best advice we can.
Yeah.
And there is a lot of information that is confusing. I just had a conversation with a patient today who looked at his pathology report and saw some things on there that scared him. But to the physician's standpoint, these are background noise issues, things that have a little bit to do with what we're going to do down the road. But his pathology report is really a good news sign.
Yeah.
And trying to help patients do that. And because patients do a lot of their own research, there's a lot of lack of trust. And that's hard on us, So I think that would be my third part. From a philosophical stage for patients with prostate cancer, I would also counsel them to really be honest with themselves about understanding where happiness lies. So many guys don't even want to screen for this disease because if they have a weaker erection, then they might as well be dead. And that's just the wrong way to think, right?
For sure.
And those guys probably need to see reference to and increase their team, because their wives will tell them that they're overthinking it. For men who are looking for more practical advice from the top 5 things, I would say my first point is to understand your risk and not to overthink it. Lots of things can make your PSA go high. My second point is to not overthink and not overreact.
Yeah.
We have a lot of people who overreact, especially with prostate cancer. Docs like me in urology, we see thousands of patients with prostate cancer. And thankfully, it is rare when we have patients in our care, it is rare to have people die of this disease, right? It's when patients are not in the care of physicians that they then show back up to clinic with really tragic, dangerous disease. It's rare to have men in the care of physicians get into real trouble. So I would say practically first is understand your risk and don't be afraid of testing. If you have genetics, don't be afraid of screening for prostate cancer. Don't be afraid to ask about it. There's still men who are way too afraid. Those 2 points are important. The third thing I said, don't overthink it, is true. This is still a disease that is very slow moving. It can be watched in many cases, but don't be overly panicky about prostate cancer. There are lots of things that make PSA go high: sexual activity, constipation, common life things can give you a little odd PSA reading. So don't panic. The third thing I would say is to get medical help. I mean, I'm biased here, but when it comes to cancers, there are a lot of people that think that Western medicine trained urologists are hurting people. And I just don't see that as true. I see the neglect of disease way more harmful. And I see patients, trying a variety of therapies because they are nervous about conventional therapy. Look, conventional therapies are the most studied, the most heavily scrutinized, and the best treatment options that we have.
Yeah.
Find physicians that you can trust, that are clear thinking in that regard. And then third, I would tell patients not to fear treatment if they need treatment. Again, 2025 is the best year in the history of humankind to get prostate cancer treatment. And a lot of their fears will be assuaged when they just talk about what makes them nervous. I had a guy in clinic just last week who was nervous about continence. Urinary control was his big issue. His brother had prostate surgery and was in diapers from that point forward. And that was a long time ago when his brother had surgery. But part of my workup in him was to say, hey, let's start you with a physical therapist before surgery. Let's involve a pelvic floor therapist and get you to understand the muscles that can help you regain continence quicker, because you will. And this guy had a big prostate, and he was up at night 3 times to pee and wasn't emptying his bladder. And I said, honestly, your urinary quality of life is going to be better with
Mhm.
surgery. And that's a huge benefit. So that kind of sums up a guy who's willing to talk about his fears, who's willing to address it, willing to trust his doc, and being able to meet modern treatments with confidence.
Yeah, that's great. I love it. I think that's a really great comprehensive list. Thank you. To all of our listeners, use this knowledge to go forward and improve your health. Seek out a healthcare provider that can get you the most appropriate screening, or urge a loved one to do the same. If you are a healthcare provider, go forward with greater knowledge to deliver the best healthcare in one of the most vulnerable and essential interactions with those that are entrusted to your care. I just need to clarify that the medical advice or procedures do not substitute for your own professional medical consultation. In addition, listeners or viewers need to be aware of the limitations of the information that was provided generally. You can find this on Apple Podcast, Spotify, Amazon Music, and YouTube at Not Your Doc Anymore. You can also find us on Instagram and TikTok at Not Your Doc Pod or Doc Watts _. And thank you to all those who've made this possible. Natalie Watts, the president and CEO of Not Your Doc Anymore, LLC. Our social media managers, Taylor Seberg, Emily Brown, Sarah Marion,